Welcome to today's talk on breaking down the basics, pediatric inflammatory bowel disease. My name is Abdul Elkadri. A bit about myself, I have no disclosures to give, but I'm a pediatric gastroenterologist at the Children's Wisconsin site. And I'm an assistant professor in pediatrics at the Medical College of Wisconsin. I am Canadian initially, and I have a BS and MD from the American University of Beirut in Lebanon. I did my pediatric training at the SUNY Buffalo site, and my pediatric gastroenterology training was at the Hospital for Sick Children in Toronto in Canada. I've been involved in research at a number of sites in the US and Canada with the Crohn's and Colitis Foundation. And I specifically focus on very early onset inflammatory bowel disease and genetics and immunology. So the objectives of today's talk is to give an overview of inflammatory bowel disease in the pediatric population, the impact of inflammatory bowel disease on pediatrics, looking at also treatment, surgical implications in pediatrics, nutritional concerns, and go over some of the resources for children with inflammatory bowel disease. So a bit about the overview. You probably are looking at this because you know a bit about inflammatory bowel disease, but very specifically, inflammatory bowel disease is a family of disorders that at its two extremes have Crohn's disease on one end and ulcerative colitis on the other end. It's becoming apparent that there's a mixture of manifestations of inflammatory bowel disease, with these being the two extremes, and every single person seems to have a somewhat different manifestation that's specific to them. But the basics are that ulcerative colitis is specifically in the colon. It starts at the rectum and goes in reverse and only remains in the colon. In Crohn's disease, there is inflammation that is through the wall and can cause scarring and stricture formation or scar formation, and it can be in any portion of the GI tract. So in looking at how many children have inflammatory bowel disease, it's estimated that there are somewhere between 1.6 to 3.1 million people who have inflammatory bowel disease in the United States. A quarter of those are diagnosed under age 18 in the pediatric age group. In looking at how many new cases there are per year, there's an estimated 10 out of 100,000 new pediatric cases per year. And at any one time, it's estimated that there are 80,000 already diagnosed pediatric patients with inflammatory bowel disease. It's known that the incidence of pediatric inflammatory bowel disease is increasing for reasons that are not clear, but we'll talk a bit more about some of the hypotheses. So there are typical GI symptoms where, as you know, or may not know, frequent or urgent bowel movements, diarrhea, bloody stools, abdominal cramping, weight loss, poor growth, and outside the gut type manifestations such as joint pains and skin manifestations like rashes. There are some things that are specific to pediatric inflammatory bowel disease, and it's thought that pediatric inflammatory bowel disease is more severe than adult onset inflammatory bowel disease for the reason likely that there is a lower threshold of sorts, either driven by genetics or some other immune response. And hence the treatment response is potentially not exactly the same as what you would expect with adults. There's also note of delay in growth and puberty, which we'll talk about more later on. And there are unique psychological and social concerns specific to the pediatric age group. As for potential causes of inflammatory bowel disease, it's known that the child of a parent with inflammatory bowel disease has an increased risk of developing inflammatory bowel disease, at least somewhere between 2 to 10 times more likely. That being said, it's not a sure thing that your child will develop inflammatory bowel disease if you have inflammatory bowel disease, as has been shown by identical twin studies. 15 to 20% of patients do have close relatives with inflammatory bowel disease, and it's known that the younger that you present, the more likely it is to have a relative with inflammatory bowel disease. On the right here is a Venn diagram of some of the factors that are thought to lead to the development of inflammatory bowel disease. They include genetics, the environment, immune response, and microbiome. For the microbiome, it's known that the population of bacteria within your GI tract is called the microbiome. And we know that these organisms react to things that you see in the environment and things that you eat. Sometimes it is implicated in the onset of disease in patients with inflammatory bowel disease, and hence why there are times where treatment of the microbiome or treatment specific to the microbiome, such as probiotics or antibiotics, may either be a form of treatment or one of the potential causes of inflammatory bowel disease. In general, it's known that the environment is a huge component of why inflammatory bowel disease is developing at a higher extent. Unfortunately, it's actually very difficult to study the environment, mainly due to the fact that it's hard to quantify things such as stress, the amount of pollution, what type of diet you have. These are things that are very difficult. It is known that genetics, on the other hand, there's been a lot of research in it led by the Crohn's and Colitis Foundation. And though there's been a lot of research into it, we are probably at least somewhere between 200 to 500 known large genes that really only explain a small extent of why we think inflammatory bowel disease develops. And overall, there is an immune response that's just really misdirected, and hence why inflammatory bowel disease develops. So let's talk a bit about the impact of IBD on children. The pediatric age group is known to have the possible manifestation of growth being affected. And sometimes this is one of those things that actually leads us to the diagnosis of inflammatory bowel disease, as some patients who have either Crohn's disease or ulcerative colitis may present with decreased weight gain. Having less weight gain over time causes your body to decrease the rate of growth in an attempt to try to conserve energy. And the inflammation that is occurring could also lead to the slowdown of growth. And ultimately, it leads to one of the manifestations that we see in the pediatric age group, which is stunted growth. It's thought that some of the causes, as I said, is inflammation, specifically causing a stunting of the growth directly. Also, other things such as treatments like steroids may affect growth. That being said, steroids are sometimes necessary to treat the inflammation in an attempt to try to control the effect of inflammation on growth. Long-term steroids are thought to stunt growth as well. Poor nutrition over time is thought to lead to the effect on growth as well. In general, when we see patients in our clinic with inflammatory bowel disease in the pediatric age group, one of the things we're looking for is how they grow, as it's known that impaired growth is a marker of whether or not the inflammatory bowel disease is well controlled. One of the things that we also worry about and are concerned about is bone health in children and teens with inflammatory bowel disease. It's known that kids who have uncontrolled disease or severe inflammatory bowel disease are likely to have decreased bone thickness, and having less thick bones ultimately leads to an increased risk of fractures. It's thought that this is due to poor calcium absorption and or due to less intake. It's also known that there are lower vitamin D levels in patients with inflammatory bowel disease. It hasn't been fully explained as to why that is. We know that patients with inflammatory bowel disease tend to have a decreased physical activity level. As I said before, steroid use, though it's sometimes a mainstay of how we get disease into remission, it also, over a long period of time, leads to poor bone health and thinner bones. And inflammation from active disease also leads to decreased bone thickness as well. So some of the ways that we optimize bone health is, in general, really to control the cause, which is the active inflammatory bowel disease. We, as much as possible, attempt to limit the use of steroids, and we ensure that there's adequate calcium intake and vitamin D intake by supplementing those things. And we always recommend weight-bearing exercises such as weight training, running, or hiking. In the pediatric age group, some of the things that are important to look at are the physical, psychological, and social effects of having inflammatory bowel disease. Up to 15% of children are thought to have signs of anxiety or depression with inflammatory bowel disease. And it's thought that this is due to living with a chronic illness, also coping with procedures, clinic visits, and hospitalizations. In general, inflammatory bowel disease is a somewhat hidden diagnosis where you don't outwardly show your disease, and you are basically manifesting it by having more stools, more trips to the bathroom, and diarrhea, things that you don't necessarily want to share with those around you. And the other thing that tends to happen is that there is a overall complicated medical and dietary treatment. One of the things I do remember very specifically in one of the annual camps is one of the children with inflammatory bowel disease who was on a specific diet came up and apologized to me as they were asking for their food that we were carrying for them. And I think that speaks to the fact that there is a real untold psychological effect that we sometimes really don't understand openly. We know that the presence of depression and anxiety tends to lead to a more aggressive disease course and a higher healthcare utilization. And I think the reverse can be said. A more aggressive disease course and a higher healthcare utilization tends to also, unfortunately, lead to depression and anxiety. So it's somewhat a chicken and egg type situation. One of the other implications, as I stated from before, Crohn's disease tends to cause growth defects, and it's quite common that parents will come and tell me that their child is the shortest kid in class, or that they're unable to be a part of a dance troupe or something because they look different than the other children in their class. And it also is known to delay puberty as well. And one of the things that are different is the delayed onset in menstrual periods. Though that might be a good thing for the treating doctor, it's the implications on a child knowing that there is a delay is sometimes one of the things that are somewhat overlooked. So what can you do as a parent or guardian to help your child with inflammatory bowel disease? I think it starts with having an open dialogue and speaking with your child and those around you about it. I think in general, it's good to have an open dialogue with your child's school. One of the things that we like to do is to provide a 504 letter to provide accommodations as well. And I think these sorts of things start the conversation quite openly with your school. Your child's school. One of the things is also to promote positive activities and social interactions. And I think one of the best activities that I strongly recommend is the annual inflammatory bowel disease camp called Camp Oasis that the Crohn's and Colitis Foundation runs around the country. This is a life-changing event for some children to know that there are people who have the same experiences that they do, and to have an opportunity to openly talk about it with them outside of the usual interactions with parents and with doctors. And I think I can't recommend it enough. I think the other bit is to talk to your child's healthcare provider about screening for depression. One of the things that is commonly done is what's called a PHQ-9. Looking for depression and anxiety. And this is recommended at least on an annual basis. And also, I think when a healthcare need from a mental health perspective is identified, I think it's always recommended to be proactive and supportive. That's at least the first step. So we'll talk a bit about treating inflammatory bowel disease in children and the specifics of it. Similar to adult inflammatory bowel disease, one of the goals is to try to improve things clinically by improving symptoms and putting somebody into what's called clinical remission, where they look and feel better. The one thing that we are now really pushing for is getting all the way to the center of this circle to histologic remission, where almost everything down to the cell-cell interaction is completely in control. And when you get to that point, it's known that patients are completely in remission. They are able to have a more steroid-free type remission without symptoms, lower likelihood of surgery, and overall better outcomes such as growth and puberty. Some of the difficulties observed with pediatric treatments include the fact that some kids just don't know how to swallow pills. We suddenly require them to take large numbers of pills, and how do you expect a 5-year-old to suddenly be able to do that? Pediatric gastroenterologists are good at trying to accommodate that, and there's been improvements in that sense. The other thing is the ability to remember to take a large number of pills. Sometimes that's difficult for adults to do. Having a child be reminded to take it, I think, is a huge step that needs to be focused upon, and something that we focus upon at each one of our visits in the clinic. At some point between their onset of disease and when they leave home, a child has to have control and has to be responsible for doing it. And it's quite often that parents, well-meaning, will try to do this a little too early and give the child the responsibility of doing it when they really can't conceptually do it yet. Another one of the things that's somewhat problematic in pediatric inflammatory bowel disease is that children have a needle phobia. They just are afraid of needles in general, and unfortunately, a lot of our treatments are currently very much based in either injections or infusions, and a lot of clinic visits are around requiring labs as well as markers of disease. Some of the things that are quite problematic is scheduling the frequent number of appointments, procedures, and infusions around things such as school time and other activities. It's sometimes hard enough to keep kids' schedules and to add on top of it very regimented type things such as infusions. It's sometimes very problematic for kids. One of the things that's somewhat problematic is that pediatric dosing for newer medications is not always worked out. And a lot of times what happens is studies are originally started in adults, as there are at least 3/4 of the people with inflammatory bowel disease being adults. There's more of the patients with inflammatory bowel disease being adult. And so therefore the data is emerging from adult studies, and pediatrics, unfortunately, is not really just a smaller version of adults. A lot of times we really don't have much in the way of data when it comes to pediatric inflammatory bowel disease and how kids respond. In some cases, we know that sometimes the response in, for example, those under age 6 is really not as great as what you would expect for those above age 6. One of the things that we don't know is that we have concerns for, there's always a concern for drug toxicity, and due to the fact that there really isn't as many pediatric patients with inflammatory bowel disease, it's not surprising that there's not as many clinical trials. Though the FDA has really pushed for pediatric specific outcomes to be looked at and pediatric specific trials, it's still somewhat currently lacking. And hence why training programs who train pediatric inflammatory bowel disease doctors or pediatric gastroenterologists really try to navigate these very tricky points and try to teach people what to do. So it's somewhat tricky for us to try to recommend what to do at times. That being said, most of the medications that will be available for adults with inflammatory bowel disease are at least theoretically available for pediatric patients with inflammatory bowel disease. Some of these medications may not have an FDA indication specifically for inflammatory bowel disease, and therefore it's somewhat tricky for us to recommend. But at the same time, under the guidance of your pediatric gastroenterologist, it's somewhat possible to be able to use a lot of these medications with a lot of data for adults with inflammatory bowel disease. Some of the questions to ask your healthcare team for your child with inflammatory bowel disease are, what are the risks of the current treatment? And I think this is one of the most difficult things for parents to do, because very frequently parents will tell me, I know what to do for myself. I really don't know what to do for my child. I know how to take risk for myself, but I don't know how to place risk on somebody else. And I think it's because, unfortunately, very frequently, a lot of times what happens is that parents are focused on the risks of the treatment plan. It's important to remember that you also have to look at the risks of not treating the disease. And most of the patients who are coming to a treatment decision have disease and are going to have the full manifestations of having a disease, or at least some of the manifestations of having a disease, whereas it's quite sometimes unlikely to have some of the side effects of treatment plans. And it's sometimes forgotten that in looking at the possible risks of a treatment plan, that you forget to look at what are the risks of not treating the disease, which include the need for surgery, again, also a lymphoma and a cancer risk, and overall the lifelong implications of stunted growth and delayed puberty and poor bone health. One of the things that is important to try to bring up with your child's pediatric gastroenterologist is, how do we manage those above side effects of treatment? One of the things that you can do, for example, for skin cancer risk, is to use sunscreen. For other medications where there's a concern for colon cancer risk, you can do surveillance colonoscopies. And in general, though, live vaccines are not recommended in patients with immune modulation, you can still do not live vaccines as well. And these are the sorts of things to bring up with your pediatric gastroenterologist or with your pediatrician. Another thing to talk about is what to do if the current regimen is not working. There's always supposed to be a game plan for what to do, and being proactive with that is sometimes very welcome and helps with conceptually thinking ahead and trying to read about some of these risks with treatment and without treatment. One of the things that's also recommended is, in cases of steroids for induction of remission, to avoid it, there is an option for nutritional support, such as exclusive ventral nutrition. And a lot of times there is a decision made by the pediatric gastroenterologist that they don't want to introduce that. And if you feel that you'd like to avoid steroids, be proactive with that discussion with your child's pediatric gastroenterologist, as it's very possible that your child's provider may be open to exploring that with you. A bit about surgery for pediatric inflammatory bowel disease. The goals for surgery is really to aim for a better quality of life, and how to do that is to really alleviate the symptoms of inflammatory bowel disease and alleviate the symptoms for what is either chronic findings such as scar tissue or uncontrolled disease. And the real aim is bowel conservation and preservation. And overall, it's to really prevent the complications of what happens in areas that are either untreated or are very difficult to treat. And one of the things that sometimes happens is if disease is completely not controllable, there is implications on growth long-term, and sometimes surgery can address that growth failure. And again, the aim is to improve quality of life. And to do that, you may need to interact with a pediatric surgeon who's a vital part of the treatment team. Some common types of surgery include, in Crohn's disease, a resection of the most commonly affected area, which is the last part of the small bowel on the right side of the colon, so the terminal ileum and the cecum, what is called an ileocecectomy. Sometimes if you have a scar area or a stricture, you can do what is called a stricturoplasty. where you can open up a narrowed portion of the bowel. In other cases where either due to something like a perianal inflammation or due to a disease that is being driven by poop going through the colon, what can be done is what's called the diverting ileostomy, or what sometimes people frequently call the bag. An ileostomy is an opening out to the surface of the abdominal wall where the stool then will go into a appliance that collects the stool, and in general, sometimes that is necessary. At times in Crohn's disease, the colon may need to be resected, and though it's not the only target, it may need to be resected due to either uncontrolled disease or chronic complications of uncontrolled disease. In ulcerative colitis, as the colon is the target for the immune problem, removal of the colon may sometimes be necessary in what's called a proctocolectomy. In this case, because the colon is not there anymore, you start out with an ileostomy to divert the stool away from the rectum and to allow healing to happen. Sometimes a second and third stage procedure can be done where a pouch can be created from the small bowel to allow for the collection of stool within the abdomen, the belly, and to then allow for a diversion of the stool back to the rectum, and for people to be able to sit on the toilet and pass stool out their rectum. There are risks with all surgeries, and these are the sorts of things to have discussions with openly with a pediatric surgeon and your pediatric gastroenterologist. One of the things that's important is that surgery is not curative. There is the possibility of recurrence of symptoms. Specifically to the J pouch procedure or the IPAA, it's actually quite common and almost expected to have some level of inflammation of that pouch, which is called pouchitis. And at times this may lead to what's called pouch failure. And unfortunately, this happens sometimes in up to 8 to 10% of patients who do have this procedure. Some special considerations for children is that kids overall, thankfully, tolerate the procedures very well. Sometimes parents are very concerned that children are more fragile. Kids are actually quite able to tolerate these procedures. And looking at their quality of life scores, it appears that kids actually have better functional outcomes than adults. So is that potentially due to the fact that they have a longer period of time to develop tolerance for the change in how stools flow through, or whether or not they just have their disease for a longer period of time, or there's something specific to the pediatric age group, is unclear. One of the things is when asking parents about their child's quality of life, it is clear that there is some suggestion that parents feel that there are some physical and psychological health outcomes that are problematic. And therefore, I think these are one of those things where it's important to focus upon mental health and addressing mental health issues in a very hard time when undergoing surgeries. Some of the specific nutritional concerns in pediatric inflammatory bowel disease include the fact that kids require nutrition to grow. And as stated before, it's very critical to have proper nutrition. One of the things to differentiate is the difference between diet and nutrition. Diet is really what you eat on a daily basis, whereas nutrition is what your body is taking away from your diet. And diets can sometimes be poor in available nutrition. And so it's quite important to focus on a proper diet to be able to give your child the proper nutrition that they need to grow and develop and to have better outcomes. It's known that careful food choices are able to lessen symptoms and possibly prevent disease. As noted from the previous Venn diagram, diet and environment is really only one portion of that cause for development of inflammatory bowel disease. And on its own, food choices are not typically enough to be able to completely prevent and control inflammatory bowel disease. And so it's helpful and it's welcome, but it's important to ensure that a child is receiving proper nutrition. It's known that children with inflammatory bowel disease are prone to becoming malnourished. And the reasons for this are the fact that they have a loss of appetite due to uncontrolled inflammation. They also have an increased caloric need to be able to heal because they have a chronic disease. And it's thought, at least to a smaller part, to have effects on digestion and absorption of nutrients. And so it's really important to focus on nutrition throughout a child's life, and most specifically when disease is not completely controlled. Some of the principles of good nutrition is that you need proper nutrition for your medications to work. Medications on their own without focusing on nutrition is not enough. Having a proper nutrition diet is able to help with healing, immunity, and overall with energy levels. It can sometimes help in preventing and minimizing GI symptoms, as stated before, and there's some emerging studies that are coming out now that are talking about that. And overall, it's important for normal bowel function and in preventing growth delays. So focusing on nutrition is really important. And as such, sometimes a dietitian is a vital part of the treatment team. During a flare, one of the things to focus on is really trying to avoid making things worse. And in inflammatory bowel disease, at times what happens is there's swelling or scarring of intestines. And this sometimes leads to a difficulty in passage of food through those areas. And so things that might need to pass through those areas undigested are potentially triggers. And what I tell a lot of families is what's specific to your child is more important than what a general recommendation is, because at times there are particular trigger foods that seem to trigger certain patients and not others. Some of the general rules are to avoid nuts, seeds, kernels, or things such as popcorn that pass sometimes undigested through the GI tract, especially if your child has strictures or Crohn's disease. One of the things that's important is to limit insoluble fiber as opposed to soluble fibers that are able to dissolve in water. Insoluble fibers include things such as leafy vegetables, wheat, and bran. Limiting them basically takes away the fiber that develops a larger stool that has to navigate those tighter areas. Some of the recommendations also include a decrease in concentrated sweets and a lactose-free diet, as sometimes sugars can cause gas, and gas formation can lead to distension of the bowel, which leads to more symptoms and triggers. And in general, especially in cases of strictures, smaller, more frequent meals are important as well. I think what's important is to, in supporting your child through their IBD journey, is to help your child take their medications and ensure their compliance with it. And it's one of the most difficult things that you have to do in teaching your child to be able to be responsible to take their meds. Sometimes some children will thankfully never have their disease active again. And as such, they may never remember what their inflammatory bowel disease is like. And in asking somebody to take medications for something that they really don't remember why they're taking it, it's almost unfair. And I think in remembering that, it sometimes is important in realizing why there's difficulties in having your child take their medication. One of the things also that's important is understanding your child's disease and possible complications, and also sharing that with your child's school and all those who interact with your child. It's important to really schedule follow-up appointments, and as stated before, life is very hectic, and sometimes schedules can be not flexible. But keeping those follow-up appointments are important to following things such as growth and development and the development of puberty. And as stated before, helping your child maintain a well-balanced diet is really important in healing and overall control of disease. It's important to establish a support system for yourself and your child, and to really balance that with empowering your child with being able to make decisions and providing them with information to be able to make those decisions. Remembering that there are times where they may not remember what their disease is like and what the implications of having active disease over a long period of time is going to be like. So for more information, it's really recommended to go to the Crohn's and Colitis Foundation's website. There's a wealth of knowledge there, and I can't recommend it enough to all of my patients. Thank you very much.